Welcome everyone to our presentation today on tools, tips, and strategies for successful toilet training. We have a wonderful presenter for you today, Dr. Daniel Mruzek, who works here at the University of Rochester Medical Center and will be sharing expertise all around toilet training. Go ahead to the next slide, please. We're presenting with you through developmental and behavioral pediatrics. We specialize in clinical services, research, and community programs through the Strong Center for Developmental Disabilities. Go to the next slide. And at the Strong Center for Developmental Disabilities, we focus on independence, productivity, and integration and inclusion for all people with disabilities. We're one of 67 university centers for excellence in developmental disabilities, a member of the Association of University Centers on Disability, which is a network geared towards advancing policy and practice for individuals with disabilities, their families, and communities through research, education, and service. Next slide, please. This webinar is brought to you through the New York State Department of Health State Systemic Improvement Plan, SIP as we call it. The project is geared around improving family-centeredness together. It's the New York State Systemic Improvement Plan through the Department of Health. Next slide. Just a couple housekeeping things for you before we get started. This is one of 10 webinars offered through September 2019 through September 2020. All webinars are recorded and available for viewing through the SCDD website, as well as our YouTube channel, which is Pediatrics URMC. And you will also see this webinar, as well as all of our others, available through the New York State Department of Health's online learning website. To receive a certificate of completion, you have to complete the satisfaction survey, which is available on all of those platforms. It's connected to the webinar, so just go ahead and find that survey link and complete that, and you will receive a certificate of completion within 2 weeks to a month. It's not an automated process, so just be patient. You can earn up to 1 hour of credit towards your professional development requirements as outlined in the provider agreement through the Department of Health Early Intervention. And if you have questions about crediting, please reach out directly to the Department of Health, as we're not responsible for the crediting side of things. Okay, so that's all I have for you today. I'm going to turn it over to our presenter for a fantastic presentation.
Thank you, Jennifer. I really appreciate that. Appreciate your organization helping me get organized this morning. And colleagues, I think we have about an hour here to cover toilet training. And it's a fun topic. It's a fun one for me to talk about. And I've got plenty of material. So I'll just share with you at the top of the hour, there might be particular moments when I hit the accelerator with some slides, and then I'll slow down on some others. That's only because I'm thinking about what might be of particular interest to you this morning. But if you see something in the slides that really captures your attention that I don't hone in on to any great extent, I invite you. Feel free. You can always send me an email. We can follow up. I'm always glad to hear from colleagues. And so feel free anytime. You'll see my email on the final slide of today's presentation. Thank you for that. I appreciate it. And just a brief note about the material. Some, but not all of this material comes from a book chapter that I and a few colleagues recently published. And we published it in a textbook called Parent Training in Autism Spectrum Disorder, Evidence-Based Approaches. It was published by the American Psychological Association last year. And I only point that out because there's like all good projects, there's a number of supporters and participants, a team that helped put together the material. And that's certainly true with many of the concepts and key items that I'll share with you over the next hour or so. So nice reference here if you want additional information. So let's see how we can do with this over the next hour. I'm more than happy to do the following for all of you over the next hour, and that is look at a model for troubleshooting stalled toilet training programs, look at common barriers. We'll look at demonstrating specific training and consultative techniques that help with toilet training, particularly in difficult training environments. So for example, teaching staff who are helping a child who might be in a home where the opportunity to toilet training is compromised in some respects, things that we can still do in order to promote acquisition of this all-important skill. And then finally, we'll look at identifying strategies for analyzing behavioral data And I probably won't drill down on that quite as much today as I might in some other settings, just because I have a sense of how far we can take things in an hour. And some of these other areas are probably a greater priority, but I love talking about data. So as we have a chance, I'll share with you a bit about toilet training data as well. So let's look at this. You know, if we wanted to be very technical about it today, we would be talking about enuresis and encopresis. And enuresis, as you probably know, is difficulty children, or adults for that matter, have in maintaining bladder control. Likewise, encopresis is the inability to control the release of stool. And technically, if the child whom you're serving is under the age of 5, this diagnosis isn't made because there's a range at which the skill of using the toilet is acquired. But nonetheless, generally speaking, one way of thinking about this today, our time together, is to think about how we're going to address enuresis and encopresis. And the story doesn't end there, colleagues, because even if one is using the toilet when, for example, they're taken there, perhaps set on the toilet by a parent, we call that habit trained, there's still a lot of training that needs to occur. Other things include self-initiation of toileting. So a child gets up at the right moment and walks to the bathroom. A second thing is related skills like unfastening and fasting, the zipper, belt buckles, these kinds of things. And then finally, this very important goal of maintenance of skill once toilet training is completed, and generalization of that skill across settings. And as many of you probably know, that generalization piece can be easier said than done. So we'll try to spend at least a few minutes on that today as well, promoting success, not just in the training setting, but in other settings as well. And there's all sorts of different kinds of problems that we need to think about as it relates to toilet training. Hey, I list a few for you here. I probably won't read this list verbatim, but just to give you a sense of the kinds of things we look at is we have children that just don't pick up the skill by an age when we wish they had, by 5, 6, 7 years old. I'll show you some data related to that in just a moment. We have children who have nighttime accidents. We have children who will use the toilet, but they're dependent upon others to take them there. Sometimes we refer to this status as being prompt dependent. They're dependent upon the prompt of others, teachers or parents, for example, grandparents. And we also have another difficulty that can crop up more often than one might think, and that is regression in skill. So a child who can use the toilet for a good period of time, maybe a year or more even, for one reason or another, regresses in their use of that skill. They actually appear as though they've lost the skill. We need to think about that as well. You'll see I have in parentheses they're ill or anxious. Well, if a child is particularly anxious, or if they have a bout of a serious flu, or if they've moved into a new house and they're keyed up, these kinds of life events or these occurrences can set the occasion for regression. Sometimes it's very temporary, but sometimes it's much more significant. And then finally, as I alluded to in that previous slide, there's a lack of generalization often, which is a concern. The child holds it all day during that 6.5-hour school day, or they use the toilet at school, but refuse to or otherwise do not use the toilet in the home setting. You need to think about that as well. And just a word about what an important issue this is, colleagues. This is something where we can really very significantly impact the quality of life, not just for our immediate client, the individual with enuresis or encopresis, but their family as well. This is an area where we can really have a positive impact on the lives of people whom we serve. Even in the general population, this is quite a significant concern. About 10.5% of youth with who are otherwise typically developing demonstrate concerns either related to enuresis or encopresis. So this is quite a significant concern. In the population of children with developmental disabilities, this is even greater. We conducted a study a few years ago. A number of students here at the university, Lend Fellows, and we conducted a study looking at the acquisition of toileting skills among children with autism. And we found that about 60% of children with autism had not yet established the use of the toilet by 4 years of age. So you're looking at the majority of children with autism by 4 years, almost 5 years, still not yet using the toilet. This is really a significant concern. If you are a good trainer of skills related to using the toilet, you, colleague, are a person who is in excellent position to really improve the independence and quality of life of the person whom you're serving directly and their family. It's really a great way to contribute, I think. I promise not to get buried in the weeds, but I just wanted to share with you, we plotted our sample of children with autism as a function of age. As that bar goes up, that is the percentage of children using the toilet independently. And you can see even by 75 months, so what is that, 6 years old? We still have a sizable percentage of children, 20% of children perhaps, with autism who are not yet using the toilet. So yeah, this is really quite a significant concern. And I'll just break this out quickly. It represents what we might intuitively think about as relates to the acquisition of the use of the toilet. And that is, as a person demonstrates greater and greater intellectual delay, cognitive delay, there is a commensurate increase in the probability that they do not yet use the toilet. And so as one demonstrates greater overall delay, one demonstrates a greater probability of needing a pull-up or a diaper. And so this is really quite a significant concern, including children with mild delay, but particularly for children who show quite significant delay as well. Yeah, and you know the implications, scholars. I bet if we were together, I wish we were together in a dialogue. It would be much more compelling in some key respects, at least for me. But if we were together, if I were to make a list on a dry erase board of some of the implications of not being able to use the toilet independently, here's some that you and I may very well come up with. Again, I won't read the whole bulleted list, but I'll just share with you a few. It's a hardship for caregivers. If a child is not yet using the toilet, their privacy is compromised, their hygiene is potentially compromised, they risk teasing, particularly in general settings, general education settings, or broader community settings. And I'll just share with you this very briefly. That is, if a child's having accidents across the school day, for example, and if people are employing half-hearted or otherwise unsuccessful toilet training procedures, so they're traveling to the toilet but not productive intermittently across the day, there's lots of lost educational opportunity. Think about it. If a child's going to the bathroom 5 times a day but not successful, or 7 times a day for that matter, if each trip is taking 5 to 7 minutes, we're talking about the upwards of 45 minutes, 50 minutes, an hour a day, 6.5-hour standard school day, where they're not engaged in other educational opportunities. So there's a real cost here for us to consider. Yeah. Right now, if we were together, I'd be saying thoughts or questions or comments. I'd love to hear what you say about that, but I'll proceed. I'll tell you what, colleagues, toilet training is a great opportunity. It's a great opportunity for helping professionals, because when one toilet trains a child, for example, with a developmental disability, in tandem with his or her caregivers, so together they tackle the problem of toilet training, all sorts of great principles of learning are inherent in the project. That is, when you teach toilet training, you're demonstrating all sorts of great skills related to how to be a good teacher, how to be an effective disseminator of knowledge. And so you have an opportunity not only to toilet train a child, but to teach his or her caregivers great ways to teach other skills. It's all there. Antecedent support, monitoring the child's behavior, physical supports, positive reinforcement for success, generalization across settings, decreasing prompting. It's all there. It's all there, colleagues. It's all there. And so this is a great way for us, again, to support families. I think that's in part why so much of my career as of late, the last few years, has really been shaped into helping teams with toilet training, simply because I find it to be this area that really positively impacts the quality of life, the opportunity, the independence of the people we serve, and it gives me a chance to impart with my constituents, families, for example, or teachers in a classroom, all sorts of great principles and practices related to teaching. What could be better than that, right? Well, let's see what else I've got here. Oh, I just want to share with you briefly, just here, in a sense, you can see I'm setting us up to talk about toilet training proper. I just want to share with you at least one other point here, and it's this. Take care to organize your toilet training intervention carefully at the outset so that you have maximum probability of success when it's implemented. A lot of my referrals as a clinician at a university-based clinic are children for whom others have injected into their lives failed attempts at toilet training, repeated failed attempts at toilet training. And here's the risk. If there's a failed toilet training attempt, not only are we not teaching the child the skill that we've targeted, but in a way, speaking about it intuitively, what we're teaching the child is that if they hold out long enough, things return to baseline. The adults in his or her life will peel away the expectations that they adapt to new expectations or new demands, or that they learn a new skill, or that they terminate using an old skill, such as voiding into a diaper. And that makes subsequent training, that makes training in the future that much more difficult. That's how I get my referrals for 14, 15, 16-year-olds who are still wearing these big bulky pull-ups. History of failed attempts. Not only does it fail to teach the child to use the toilet, but it inadvertently shapes resistant behavior that makes subsequent toilet training attempts that much more difficult. So in a sense, this is a bit of a warning slide to you, a warning moment when I point out to you that take this on as serious stuff that you and I want to train very carefully, that we want to prepare for very carefully in order to maximize success. Okay? Now, this is really small font, I understand, at least it is for me in my aging eyes, but I just want to share with you that if you remember that this slide, it's slide 21, I outline a basic set of targeted goals one needs to review in setting up a toilet training program. And by and large, we're going to walk through this over the next hour, so I won't perseverate on this slide for current moments, for current purposes. But nonetheless, I just want to point out to you, if I were a teacher, or if I were a special education provider, or if I were a parent, and if I were looking for some brief out-of-the-box guide for how to organize a toilet training program, I might think about this particular slide, slide number 21, because in this slide, I bulleted out most of the key considerations that go into planning. You can see that there, establishing the goal, considering barriers, thinking about what supports are needed, asking yourself, how are we going to know if the child's making progress? What's the data system? What is the reinforcement for success so that we can shape on that success and drive it up, accelerate its occurrence across subsequent training opportunities? How are we going to discontinue disposable undergarments? What precursor behaviors, what signal behaviors set the occasion for urination or defecation? What should we look for? For example, the potty dance. Talk more about that in a bit. What's the training schedule look like? And then finally, how are we going to coordinate this training with the other relevant persons in this individual's life? A teacher might be thinking about caregivers. Caregivers might be thinking about daycare providers, so on and so forth. Okay? So think about that. That's slide 21. And if you were looking for an out-of-the-box guide for how to set up a toilet training program, this might be helpful to you. Likewise, once you initiate a toilet training program, so once that toilet training program is up and running, almost invariably within the first few days, and then perhaps once or twice along the way, there's going to be some very significant concerns. There's going to be some barriers, not the kinds of barriers that derail success necessarily, but there's going to be some significant things to think about. That's natural. Anytime we take on a big project, whether it be toilet training or building a house, whatever the goal is, there's going to be these moments along the way where we have to stop and troubleshoot. And so I just want to, in a sense, set you up for that so that you can be successful at those moments where there are barriers to success. And I have here just a quick little discussion guide. So imagine a teaching team with parents, teacher, classroom aides, therapists, perhaps administrators coming together to think about how to promote this child's success using the toilet. They've got a program in place. It's been in place now for a week. There's some problems that they're seeing. Here's a brief way of organizing that troubleshooting meeting. Just a brief outline, if you will, just a way of setting things up. I usually ask, for example, if I'm training at home, I'll ask the parents about their impressions of overall progress. How do you think it's going? And then I listen very carefully to what they say. Secondly, I review the data. So in a sense, I'm getting a subjective report and then an objective review. And then I'll review the training routine and get a sense of the extent to which it's being carried out Is it being carried out with reasonable fidelity, or for a whole bunch of reasons, or one in particular? Is it being pushed to the wayside? If the child's not getting lots of rich reps, then you can't expect a lot of progress. True? And so I'll check that. And then I'll look for specific barriers, and we're going to drill down on that in some specific slides. So I'll hold back there for the moment. And then at the close of the meeting, we'll determine some very specific next steps. Okay, so again, the previous slide is simply an overall guide towards constructing an individualized toilet training program. This next slide here is, once that program's in play, when you come back together, count on there being some challenges that need to be dealt with. And here's a brief troubleshooting guide. Here's a way of setting up that meeting where you talk about those challenges. Okay, excellent. Let's see what else we have. Here's assessment. Hey, here's a question for you related to assessment. Is my child ready for toilet training? Have you ever heard that question before? I bet you have. Well, I just stole this from a standard pediatrics textbook. It's on my shelf right back here. I just looked and saw what the pediatricians recommend to the general population. When parents come in and say, hey, is my child ready yet? Here's the kinds of questions they look at. And again, I won't read this verbatim. You can see it there in front of you. But some of the keys include, do they stay dry for intervals of time? Does your child follow simple instructions? Like if you ask them to set a book on the counter, will they take it over and set it on the counter? Or drop a plastic cup in the sink when you ask them to? Will they come when called? Do they demonstrate a desire to please the caregiver? Do they demonstrate any kind of interest in using the toilet, like watch siblings or parents when they're sitting on the toilet, express any kind of interest in doing that themselves, or ask what's going on, these kinds of things. These are all golden signs of readiness. Hey, but how about children that demonstrate some type of developmental disability? Then the questions are a little tougher to answer, because almost by definition, we're dealing now with a population who are developing atypically. And so some of the standard questions, though they may very well be appropriate, might not be the only questions we need to ask. And so here's some other ones I want to share with you. Here's how I go about it. I ask those standard questions that I reviewed a moment ago, but I don't end there. I also ask, just generally speaking, is the child's developmental level in that 2 to 3 year range? That's an indication that they might be ready. I just intuit, just about where are they functioning, generally speaking. Intuitively, does it sound reasonable that now would be an appropriate time in their developmental trajectory to train? If so, we might be on the right track. I'll also ask myself, do they cooperate when given direct instructions from adults? That doesn't mean that they have to follow every instruction every time. In fact, many children do not. You know that, don't you? But do they cooperate when teaching staff or parents are imparting instructions? If not initiating, are they at least cooperating when they are intervened by their parents at a particular moment in time to follow through with some task, putting things in a hamper, cleaning up toys, or something like that? Do they follow simple routines across the day? In a classroom, it might be, do they give some indications of understanding that it's cleanup time or time to come to circle? That's gold in terms of demonstrating some basic readiness for toilet training. Do they show some subtle signs of awareness that they have a full bladder or that they're about to defecate? For example, you know the classic, the child who does a potty dance? Perfect. Recognize, though, that a child with autism or other developmental disability may not show the common signs and symptoms of a full bladder, for example. They might stand behind their dad's favorite chair, or hide in a closet, or gravitate towards their bedroom. Or if the child's generally speaking nonverbal, nonetheless, when they have that full bladder and they start to feel that pressure impinge, they may very well drive up their nonverbal vocalizations. They might get louder, or they get more motorically active, running from one spot to another more rapidly. I had a child who would attempt to go out and sit in her mother's car prior to defecation. And at first her mother thought she was going out there to play, but the more she thought about it, she realized that it was the ultimate nice quiet spot to relax at. And that became a nice sign for us that she was actually ready for potty training as related to bowel movements. So the moral of the story here at the moment is, when you're thinking about readiness, think about those possible signs of awareness on the part of the child. And don't only look at the very obvious ones like the potty dance, but investigate some of those other more idiosyncratic and very individualized type signs, or those very subtle signs that might get past us at first blush. You have to be like Sherlock Holmes to a certain extent with this. Hey, now here's the thing. Even if there's no reliable precursor behaviors, it might be that the child can be at least habit trained. One of the things that happens, just to jump ahead, is if you jump in with your toilet training and that toilet training is implemented with not perfect, but reasonable or strong fidelity, often after a few days, a week, 2 weeks, it's very child specific, the duration before this happens. Very often though, the child will begin to demonstrate precursor behaviors as a function of having had this now rich experience of being taken to the toilet on a regular schedule and being dosed with reinforcement for sitting there quietly, or perhaps being reinforced for inadvertently getting a urine stream in the bowl. That'll begin to shape on the occurrence of those precursor behaviors. We'll call that habit training. That is training a child to at least release their bladder, for example, when they're set on the toilet. Okay. You didn't know this was this interesting, did you? It is. Finally, in terms of readiness, I'll just share this with you. Here's what I really look for. Like if I really had to drill down, I'm on a difficult consultation and there's lots of hemming and hawing about whether or not a youth is ready for toilet training. I ask the following. Is she usually following simple instructions, like dropping a cup in the sink, like I say, when asked to? Can they sit calmly on the toilet for a couple of minutes, 90 seconds, a couple of minutes? And as long as they're not severely resistant to the toileting task, as long as they're not physically aggressive towards others or self, we may very well be good to go, at least with the habit training. Okay? So those are kind of the bare minimum requirements in terms of developmental readiness. Again, I'd ask you thoughts or questions if I could. I just have to assume we're all on track for current purposes. Yeah, why do they have these problems? Well, for a whole host of reasons. And if this were a more interactive procedure, I'd stop right there and ask you to shout out some reasons. I always learn a lot from all of you. It's one of the reasons I add those things. Send me an email if you care to. I'd be glad to hear from you. Okay, so now you're thinking about toilet training. A child, for example, a young child, perhaps a child in early intervention or kindergarten or first grade or something like that. What's one of the first things you do? Don't overlook this step, colleagues. Rule out medical concerns first, because we're already looking perhaps at a child who's developing atypically. If we're looking at a child who's been identified as requiring specialized early intervention or specialized schooling or therapies or additional support, we're already almost by definition looking at a child who's developing atypically. As a function of that, there's a higher probability that they may have some physical concerns that need to be considered carefully. Here's some right here. And again, I just pulled these out of my textbook I had back here on my shelf, the Eyerember and Schwaderer 2009 textbook of pediatric care. I won't read these verbatim, but there's a number of things that a physician will look for. Now, here's how I do it in practice, in case you're wondering. What I do is I ask the parents to take the child to the child's pediatrician and simply ask the pediatrician very honestly and directly, we have somebody who's very interested in setting up a toilet training program. He wants to know if there's any rule outs or any medical concerns we should consider. If the parent comes back to me and says the pediatrician says we're good to go, or very often here in the university setting, I get something through electronic medical record from the pediatrician. They can jot me a note and send it a HIPAA protected message to me. They'll say, good to go, or thanks for trying this, or something like that. And then I can put that to rest, at least for current purposes. If I think there's a concern later on, I might revisit with the pediatrician or see a GI expert. But generally speaking, that's how I go about ruling out those medical concerns first. Is just invite the parents, touch base with the pediatrician, make sure there's not something there I'm missing. Okay, well, I'm a psychologist. I'm a behavior analyst, but I'm a psychologist as well. And by virtue of that, I have to have at least one Venn diagram in every workshop I give. So here's my Venn diagram for today's purposes. And what I did here is I just added some of the key concerns that I invite us to think about related to barriers to effective toilet training. One is that we're often working with a population that just by definition needs extra reps. They take longer to learn a skill. In some key respects, that's how they got identified as needing extra help. Is they are learning skills more slowly than most of their peers, and that is going to include toilet training. The second thing, just going around it like the base of a clock, the child, for example, with autism or with other developmental delay, they're often going to demonstrate an aversion to toileting. And that means they're going to demonstrate what we call anxiety. They're going to look anxious, either approaching the toilet or sitting on it for any length of time. That becomes a barrier. Also, don't overlook the possibility that the child either has current GI complications, like what? Like constipation, very often, or they have a history of constipation. And what comes along with that history often? A history of pain associated with the toilet, discomfort associated with the toilet. And that's a history we're going to have to unravel gradually across time. So many of our children, for example, with autism, they have atypical diets. You know that, don't you? And by virtue of that, they're at a greater probability, they have a greater probability of experiencing constipation at some points in their lives. That constipation is discomforting. And if the parents are taking them to the toilet to try to resolve that, the toilet becomes associated with that discomfort. And you're going to be working against that as you initiate your toilet training program. So it's good to recognize that as a possible barrier. And then finally, each of the students, each of the children, each of our constituents whom we train, they have this learning history that is not including use of the toilet. What are they doing instead? Instead, they're often defecating or urinating into a disposable garment. That is a competing learning history. They have this well-established routine. This is, and very often, this has worked out great for them in their young lives. They wear this disposable garment, they go at their leisure, and then a parent or caregiver cleans them up. And this has worked out quite comfortably for them. So there's the four key areas that I've identified as barriers to effective toilet training. Slower reps, slower rate of learning, more reps, I should say, slower rate of learning, requiring more reps, best way to put it. Anxiety, possible GI complications, either currently or historically, and then a competing learning history. Here's those GI complications again, and I for today's purposes, you might see me bump through this pretty rapidly. But I encourage you, if there's any concerns whatsoever expressed by the parents related to constipation, for example, touch base at least with the pediatrician, and if the concerns are significant, perhaps with the GI expert, because it could be that there's a physiological reason as to why this has been a difficult skill for the child to master. We might as well know that from the outset. It saves them a great deal of grief and saves us, frankly, from a great deal of grief as well. And as I pointed out, that history of constipation can set the occasion for significant avoidance reactions on the part of the child. It ramps up their anxiety. Now, here's the second one. Remember my Venn diagram? Constipation. Here's the second one. It was up on top. Slow rate of learning. This is very common. This is, in terms of troubleshooting, this is often our bread and butter, where we spend a lot of time considering. Most children who are identified as requiring individualized help, such as an IEP or early intervention services, they're demonstrating a decreased acquisition in a decreased rate in the ability to acquire new skills. And that's going to include toilet training. And so considering very carefully how we can support the learner who has that slower rate of learning is key. And so we'll spend a little bit of time on that. One of the keys here to share with you is repetition is going to be the key. And so, for example, for toilet training for urine, one of the things that can be really helpful is just during training sessions, during those portions of the day when you can really train carefully and intensively with the child, just giving them a little extra fluid, not a lot, but just a little, like a Dixie cup extra of water with their snack. Get them to have a sippy cup that they put some extra cc's in. That's going to give you some extra reps during the day. And extra reps means greater opportunities to be successful and be dosed with reinforcement. And you're going to take that learning curve and you're going to steepen it rapidly. It's one of the nicest things we can do. And I just want to point out to you too that for children who learn more slowly than others, they'll demonstrate much more obvious peaks and valleys in variability. That is, they'll have good days and bad days as they're assuming this new skill. That's true for all of us. Think about my golf swing, for example, how variable that can be across 18 holes. I'm still a novice. I've only played golf for 30 years. And it's with that in mind that children who are just acquiring the skill of using the toilet, they're going to give you these incredible peaks and valleys, days when they're right on and days when the bottom falls out. That's just the schedule of a novice. That's just what it looks like when somebody's learning a new skill. They have peaks and valleys. That's why us as golfers, we always say, why couldn't I hit it like that every time? Well, because I'm a novice. I don't have the consistency yet. I demonstrate variability by virtue of the fact that this is an emerging skill for me. In the same way, children who are just learning how to use the toilet, they'll have these great days where we're having all sorts of parties because of their success. And then the next day, well, what happened? Why can't you do that every day? Why are you having? Well, because they're novice. And I just point that out to you so you recognize that and you don't become frustrated or downhearted, downtrodden with regard to the rate of progress. That's normal, that variability. That's what that looks like in the novice learner, particularly for one who's learning at a slower rate than most others. Okay, so plenty of reps, as we're going to see, rich reinforcement, and then expect variability. 3 things to consider there. There's some others there, but I'm going to keep rolling. Yeah, busy slide. This is more to nudge me than for you to read. But, you know, there's lots of reasons why children learn at a slower rate. And everything we know about good instruction during the day comes into play. So everything related to supporting the child with fine and gross motor delay, clear-cut communication, the use of visual supports, having models such as same-age peers, oftentimes siblings, using the toilet. They don't have to watch them using the toilet. Just seeing them walk in can often be powerful. Note, it's not only walking in, it's using the toilet and then seeing that peer come out and get dosed with reinforcement. That's what's powerful. That's what makes social learning powerful. It's not just seeing people engage in a skill, it's seeing them engage in the skill and then that same person comes in contact with reward. That's what we do. That's what we mimic. We are biologically driven to imitate the behaviors of others that come in contact with reinforcement. That's what we do. That's how we're wired. And so those are some of the things to consider as it relates to slow rate of learning. Here's more. Make sure you schedule some trips to the bathroom. Reward successful toileting. Initially, it might just be praise for sitting on the toilet for a couple of minutes. It might just be reinforcing just some inadvertent drops of urine that hit the toilet bowl. And it might just be quick spurts, or it might be an established stream. But take whatever the child's giving you at different points in time and shape on it through powerful reinforcement. Pair it with praise, an indication that they're successful, an optimistic, you're getting it, this is going to happen for you, and then give them something, perhaps something tangible that they really enjoy. A favorite video on the iPad, a song that they enjoy. Turn on a wind-up doll that dances in front of them. Give them access to their favorite cause and effect toy. Whatever it is that they happen to enjoy, get it to them quickly. Get it to them quickly. Immediacy counts. The value, the power of reinforcement diminishes rapidly as you get seconds away from the behavior of interest. So the child urinates, bang. Shape on that behavior with powerful reinforcement as quickly as you can. Okay. Another quick strategy I just throw out to you, almost in rapid fire way, is simply this. Another nice thing we can do is check the child during the day. Imagine a preschool teacher, somebody who knows the child well, is comfortable with this, checking them, you know. Oh, I love how your diaper is so clean and dry. You're getting a little extra reward. Good job keeping dry pants. You're going to be using the toilet here pretty soon, aren't you? And so you're dosing not only their attempts at using the toilet or their uses of the toilet, depending on where they're at in that training cycle, but you're also dosing self-management of the urine stream so that you're giving them reason to think twice before they release into that diaper, or preferably, as we'll talk about in a moment, their cloth underwear. Okay? Sometimes it's helpful to engage in positive practice for accidents. Don't allow this to be punishment per se, but rather the child has an accident, either they're wet, soiled, or the floor or the seat is wet or soiled, don't make this a reinforcing event. That is, don't engage in lots of sing-songy, fun, enjoyable interaction with the child, but rather have them engage with you in a very matter-of-fact cleaning. And then simply maybe for a minute, just so they get a sense that, oh no, this belongs in the toilet. It's a little bit like your tone of voice at that moment. It's not punishing. It's not like, you better never. Rather, it's a bit like this. Oh boy, I know you want to go out to play, but it's raining right now. Imagine how you might say that to your own children when they want to go out to play in a rainstorm. Oh, I know you want to go out. Not right now. Find something indoors. You're not being punishing or harsh. Oh, you're just putting them on notice. Not like this. This will go in the toilet. And that gives you a chance to really impress that upon the child, that now there's an expectation. They use the toilet for urine and or stool. Okay? All right, so there's a brief list. Scheduled trips to the bathroom. I'll share more with you about that. There's more there about the scheduled trips, but for current purposes, scheduled trips to the bathroom. Reward success and approximations of success. If the child's just getting started and they've never urinated in the toilet, just reward them sitting on the toilet for 60 seconds, 90 seconds, 2 minutes. Reward that drip that got in the bowl. Reward them for that drip that got in the bowl. Reward them for a quick spurt. Reward them for establishing a stream. That might be 2 weeks. You see where we're headed? We're going to shape on that behavior gradually. And then consider dry pants checks and praising them for remaining dry. And then without applying reinforcement, encourage them to participate in some way with the cleanup, just so they get a sense of, oh, this belongs in the toilet. That's the message. Okay? All right, let's look at more. This is fun. I hope you think it's fun too. I want to check the time here. Got it. Yeah. Okay. Hey, here's something I wanted to share with you just briefly. If I only had 5 minutes with you, one of the things I'd share with you, I'd have this bulleted list of things I would share with you in 5 minutes. One of them would be, who's ever toilet training the child, make sure that you as the support person are reinforcing their training efforts, because it can be very laborious and there can be a very lean schedule of reinforcement for training behavior. So if you're helping a parent to toilet train, for example, make sure you're encouraging and supportive and reinforcing of their efforts, because they're all alone in the home setting attempting to toilet train. The child's not necessarily appreciative, and the reinforcement is where? Until there's some urine streams in the toilet, it's a behavior, toilet training, being the trainer, engaging in training behavior. It's a behavior that's on a very lean schedule of reinforcement, and parents and or teachers or others are very much at risk of burning out. That is, that behavior, that training behavior can extinguish very rapidly by virtue of the dearth of reinforcement. So check in with your trainers rapidly, support each other in the classroom, encourage each other. It's very, very powerful for almost all of us to appreciate social reinforcement. That is, when a colleague says, hey, I saw you toilet training today with Tony. You're doing a great job. I really appreciate your effort. Here's a parent I had HIPAA permission to email back and forth with her. She was actually up in the North Country and I'm in Rochester. So there was good reason to have a flexible way of communicating with each other since she couldn't come into the clinic. So it was Zoom with follow-up by email. And there was a day when she had sent to me what I asked her to send to me. And that is, I want to know the first day he really establishes a stream into that toilet. I want you to tell me. And here was a text I got one morning. She literally said, here's your email, smiley face. He had 2 full voids. Do you know what I did? I stopped everything. And I immediately called her. And I consecrated her training behavior with, excellent work. I'm so proud of your son. I'm just so pleased with you. I'm so impressed. I'm so grateful to you for following through on our plan. You're doing great. This success sets the occasion for future success. You are on your way. Your son will soon be a reliable user of the toilet. So she's getting dosed reinforcement for that training. That's as important as anything we can do, particularly as it relates to the child who learns at a slower rate than most other children. Okay, all right, let's carry on. Yeah, a couple other things. I knew I wouldn't have a great deal of time with you today, so I bolded just a few things here. Take special care to identify high probability times of day. That is, those periods of the day when the child's most likely to urinate and or defecate. Get them to the toilet. For many children, it's 15 minutes after a meal or after they've had something substantial to drink, right after they've got off the bus or during a morning routine, late in the day before the bus. You'll know, I'll show you some data sheets here in just a moment that you can capture some high probability times a day. I'm teaching 2 classes today, so I'm about to call you scholars. Colleagues, please heed this. Do what you can to keep the toilet training routine relaxing. None of us at any point urinate on the toilet or at the toilet when we're tensed up and nervous. Doesn't happen. In fact, I don't know if you know it or not, but kids even have a phrase for that. They'll say, I remember my son saying at the New York rest stop, saying something like, oh, I didn't go because I had stage fright. There was all sorts of people around me. Well, he was keyed up in that rest stop. And what happens? The muscles constrict. And it's the last thing you're going to do is urinate. And so that's true with our trainees as well. So take special care early in your training with the child, with the individual, to maximize the probability that they can settle in a little bit. Not fall asleep. This isn't a discussion about falling asleep on the toilet, but at least sitting calmly and quietly. As a trainer, you'll need to put your electronic devices away because that's often very distracting. They want to track that. Make sure that people around him or her are very quiet. Use as few words as possible. If it helps, dim the lighting just a bit. Have something that they can hold, which is a good idea, but nothing that's too stimulating. Usually a good, thick picture book for a young child is good. And then encourage them. Speak like this to them. Hey, this is a good time for you to use the potty. I'm going to be quiet now for a moment so you can really relax. You're doing a great job. I'll be here. So they can really settle into the toilet training. Think about how you can maximize the extent to which they relax. Okay? Minimize unnecessary spoken language and use powerful and immediate reinforcement. You're starting to see a theme here, aren't you? Use powerful and immediate reinforcement. That's what shapes on that bladder control behavior. It's up and down the spinal cord initially. That ability to exert control over the onset of urination. And so reinforcement shapes on that nervous tissue, if you will, and increases the probability that the child's going to hold that urine and release that urine once they're on the toilet. Reinforcement serves to shape on that ability. Make it immediate and powerful. Share more with you in a moment. Hey, consider adaptive supports. I know a lot of our kids, for example, with autism, they're actually physically, they're pretty fit. You know, they get around pretty well. But many of our children with other developmental disabilities may not. And even children with autism often demonstrate some mild gross motor and or fine motor difficulties. So imagine a child sitting on the toilet, a little tiny child with Down syndrome, and you're asking them to urinate in the toilet bowl. And really what they're concerned about is maintaining posture while they're on the toilet, not falling off it, trunk control. And so sometimes those little arm rails can be nice that they can kind of hang on. The seat, of course, that modified seat is a great blessing for many children. And then finally, make sure that their feet, I wish you could see this. If we were together, I could show this to you, but you'll just have to imagine. Make sure that their feet are perpendicular, their legs, the top of their legs, are before the knee bends, is perpendicular with the floor. So they're not dragging down like this, or they're not up too high like this, but that they're reasonably flush, perpendicular with the floor. That's what that looks like. That's why the footstool is often so helpful. Okay? We don't want to strain. We don't want to pull on that area, those muscle groups. Instead, we want to promote a relaxed response while the child's on the toilet. Take some time to think about that. These are all things that accelerate that rate of learning. That's why I mentioned these here. And I'm guessing many of you know all about visual support, so I won't perseverate on that today. But as I mentioned earlier, think about what you can do to really maximize the probability that a child understands the routine, including the reinforcement at the end. Use this as an opportunity to drink a sip of coffee. Are you seeing the motif here that I'm developing? And use powerful reinforcement. Immediate presentation of reinforcement, or nearly so. Don't wait 5 minutes. The reinforcing value of that item or activity or experience is virtually nil after 5 minutes for many young children. You gotta deliver that reinforcement within a couple of seconds if possible. After the child's ended urinating, for example, that's when you can get in there and light up. Now, you might not be able to present them with gummy bears then, they're on the toilet and everything, I understand, but you might have a visual support. Gummy bears, you might get right up into their sweet grills, right up to their faces, and you might just say to them, "You did it, I'm so proud of you, you've got gummy bears, awesome," so that it's nearly immediate. Behavior, reinforcement. A tight temporal relationship, one occurring immediately after the other. Behavior of urination, reinforcement. Being tightly packed in time increases that rate of acquisition. Okay, so even if it's not the tangible reinforcement, like the gummy bears they're going to get out in the hallway, it can be some representation paired with your smile and your genuine praise. "I love how you're making progress. I'm so proud of you. You've done it. Gummy bears for you, my friend." Something like that. Okay. Oh boy, this is a good question. Thank you for asking. What if the sensation of a wet or soiled diaper doesn't bother her? Almost always, I strongly encourage, on the first day of training, there's no more diapers, no more pull-ups in the child's environment. Classroom setting, for example, EI setting, for example, home, for example. I have a child right now who will be starting toilet training on Monday, and the parent has on the calendar, this is a 9-year-old, the parent has on the calendar, no more diapers on Monday morning on that calendar. She's pointing to him every day. This will be when the last diaper is available. There'll be no more on Monday. Just because we really want to set the occasion. We want to maximize the probability. We want to foster the mindset that now is the time and you can do it. Diapers don't share that message, do they? Also, by pulling that moisture away, it decreases the probability that they're going to be interested in using the toilet because they're not uncomfortable. And whether you remember this or not, you and I, in part, how we learned how to use the toilet when we were tiny, was because we were uncomfortable. We didn't like cold urine up against our skin. We didn't like the feces coming in contact with our skin. Whether we remember that or not, that was a negative reinforcement paradigm. We began to want to avoid and or escape that condition, that noxious condition. And in a sense, we need to allow that natural occurrence to happen for our learners as well. And so I recommend just discontinue those disposables as soon as you can. Then recognize that even if the child demonstrates no precursor behaviors, no signs or signals of impending urination or defecation, across subsequent days, by virtue of the fact that they're now in cloth underwear, they may very well. You're teaching them how to engage in precursor behaviors for all practical purposes by virtue of this new training paradigm that you've injected into their experience. So after a few days, you might see them start to vocalize more or rock back and forth, and that's going to be your tell. They have to learn that this is uncomfortable. Once they learn that, very often they'll begin to demonstrate what can be initially these very subtle signs of impending urination or defecation. Now, this is completely intuitive, and the analogy is not great, but it always reminds me a little of how my wife would feel that she was going into labor. We have 4 sons, and I remember when she would go into labor, at first she would look at me and she'd say, "I don't know if that's a sign or not. It just feels a little bit like a butterfly." That was with the first one. We would just wait until she was more in the throes of labor. But by the 4th one, when she would say, "I don't know if that's a sign or not, it feels a little bit like butterflies," I'd cancel work that day. It was time to go. And in the same way, at first, the precursor behaviors demonstrated by the child, you might be asking yourself, "I don't know if that's a sign or not. Maybe it's just a little more active." Remember this conversation. That might be your sign. That might be the precursor. And all things being equal, you might even assume it is, and you can shape on that behavior. Okay? It might be a good time to take them to the bathroom. Take them when there's a high probability that they're going to go. Also, people will say, oh, she's so quick, how do I know when she's going to go? Well, yeah, well, fair enough. I understand that you're right, they are quick. I mean, they're not waiting for you. They're just going when they have to, probably. And recognize that every minute that they haven't gone, there's an increasing probability that they're about to go. And as I say, you can stimulate urination with just a little extra water, like a little Dixie cup in those training intervals, and then watch for those subtle precursor behaviors and then get them in there. The pattern's variable. Here's a child in the classroom. I name him Cosmo. I name all my characters after, I name all my children after Seinfeld characters. And so here's Cosmo. He's a 5-year-old with autism in a little special education classroom. And you can see there's a little pattern of urinating in the morning. And again, in the afternoon looks pretty good too, around 1:15 or so. And so I'm thinking about, well, in the morning after the bus routine, give him a little liquid, and by about 9:35, I want to get him in the bathroom and see if I can't get some urine in that bowl. That's a behavior I can dose with reinforcement. And then again, in the afternoon, perhaps when they come in from the playground, about 1:35 would be a good time to take them in there as well. Not perfect, not perfect. This is a game of probabilities. There's no doubt about it. Okay? There's variability in all of our behavior, including variability in urination and defecation. But we can play the odds a bit just by getting a sense, collecting a little data on when the child's most likely to go. And then somebody might say, oh, I know, but progress is so slow. I know. Sometimes progress can be slow. But if you've had several days with no progress whatsoever, it's a good time to troubleshoot. Maybe at 1 week, troubleshoot. Remember that troubleshooting planning guide I showed you at the top of the hour? It's a good time to come together as a team and think about some fresh reinforcers or some additional adaptive supports, or monitor together what the precursor behaviors might look like, or make sure that the diapers have been indeed discontinued. There's things there that we can do perhaps after the first week to help troubleshoot that. Sometimes progress just is slow. And that's a time too when we can really support each other, encourage each other, because when one's engaged in toilet training, it's difficult work often. Your back starts to hurt from helping the child to the toilet. You sit there quietly, it's an echoey room. The child's not necessarily appreciating being in there all the time, so there's a little pushback on their part. You're alone with the child, you know, and so you're missing out on other things. And so there's a dearth of reinforcement there. So who's ever doing the training, everybody else, all the other adults around that trainer need to reinforce that training behavior and trade off if you can as well. The training, because it's hard work. There's just no way around it. That's, again, how I get a number of my referrals is it's just so arduous that it just is given up on before that pattern of using the toilet is established. In the interest of time, you can read through these at your leisure. These are pretty self-explanatory. So I'll step on the gas here just a little bit. There's this competing learning history that I wanted to point out to you as well. It's another one of those barriers in that Venn diagram I had for you earlier. There is a stimulus control property to the behavior of urination. We urinate under certain conditions. For most of us, it's standing at, typically males, or sitting on the toilet that sets the occasion for a release of bladder. For a child who has a history replete with diaper use, that stimulus control property is not with the toilet, but rather with that disposable undergarment. And we need to recognize that. So there's things we can do there. We can shape on their history by introducing use of the toilet and reinforcing approximations of urination while they're on the toilet. Pre-teach with a social story. Have family members model toileting can often be very helpful. Again, I'll step on the gas just a bit. You can look through that at your leisure. Notice how they're different color, these vignettes, and so you can go back and take a look at those. There's also something that is very crafty that was actually pioneered here in New York by Louis Selly. He was a New York-based behavior analyst, psychologist who published on this little procedure. I call it the modified diaper technique. And what we do is for a child who's really stimulus bound, that is, they'll only urinate when they have a diaper on them, such as the child who will go 6.5 hours, and then when the diaper is put on at the end of the school day, they urinate on the bus, and by the time they get home, the diaper's like a bowling ball. You know that routine? Here's what you can do. You can modify the diaper, put it on them at the time that they are going to toilet train, and let them urinate into the diaper. Initially, they might just have an intact diaper and sit on the toilet, urinate into the diaper. At least now they're on the toilet. You've got a behavior you can reinforce. This is a dummy there. You're giving them. Oh, I love how you did that. That's great. And you guessed it. How do we modify the diaper? You take a pair of shears and cut a hole in it. So now there's a urine stream that can land directly into the toilet, despite the fact that the stimulus that is associated with a lifetime of urination is still on that child's body. And so now that you're establishing a urine stream into the toilet, another behavior you can reinforce, and you guessed it, across subsequent days, you can gradually make that hole bigger and bigger until I had a child a few summers ago who actually had no diaper with the exception of that elastic band. They didn't wear that band like a belt, but they just held onto it, and we actually put a PEX card on it that said, I need to use the toilet, represented by picture. And so when he grabbed his band, we said, thank you for telling us you need to go. A modified diaper procedure. That helps overcome that history. Remember this? That history of urinating and or defecating in a way that does not include use of the toilet. We can overcome that through a systematic bathing procedure using a modified diaper, just increasing the size of the hole, i.e. decreasing the amount of diaper that's on the child's body until it's no longer there. Here's a child, just very quickly. Here's some data I collected. I'll spare you the details, but you can see that the black bars are toilet hits, and you can see that I was having zero success at all until I used that modified pull-up there. Do you see that right in the center? And then look at all those black bars. As soon as he could wear that modified pull-up, I got him up and running, and then I could fade that for him, and so that he could be successful. At the end there, by day 73, this was a child who no longer would ever, as far as I know, use a pull-up again for the rest of his life. And he would be, oh, I'm getting so old. He would be in high school now. And this isn't formatted properly, but I wanted to drop it onto a PowerPoint slide. But there's a simple kind of social story that one can develop. You may need to use less language, I understand, depends on your client, but nonetheless, just a sense that there's an antecedent condition. A few times a day I need to pee. There is a set of skilled behaviors that one engages in when one needs to pee, and you can read through that at your leisure, but essentially using the toilet. And then there's a consequence for using the toilet, and that's going to be a reinforcement, plus praise, plus my parents are proud of me. You see how I set that up? Antecedent, that pressure of a full bladder. The behavior, the skilled behavior of using a toilet. The consequence, positive reinforcement, dosed out, contingent upon use of the toilet. That's your social story. Simple, just like a television commercial, really. There's something you need. Here's what you do. Go to the dealership. And Toyota, what a feeling. It's just a simple ABC paradigm. Okay? Yeah. Many of our children, checking the time here, forgive me. Got it? Okay, we'll be wrapping up. In case you're wondering, we'll be done in 10 minutes. Many of our children are prompt dependent. And if that's the case, we can engage in what's called prompt feeding. Many children, we get that urine stream into the bowl pretty reliably, but only when we nudge the child to go there. Only when we direct the child to go there. Only when we say, before you play that video game, you better get in that bathroom first, because you know what will happen. That kind of thing. We need to decrease that prompting in order for that child to be what? To be independent. True? Well, we can do that. In fact, we can use what's called a prompt feeding technique. And that is thinking very carefully about how intrusive we are with the child in order to get them to the toilet, and then systematically fading off that intrusiveness. So look at this little prompt hierarchy I've established. It's that middle line with the arrows. Initially, the parent might be taking the child gently by the shoulders and saying it's time to go. That's very intrusive physical guidance. Then they can take care to not touch the child, but say, it's time for you to use the bathroom now. They might have to pair that with a gesture, maybe minimal physical prompting, like literally a finger on the shoulder. And then one can simply use a gestural prompt or a picture. And then one can reinforce the child's independent initiation of going. But for current purposes, simply what I want to share with you is that if a child is dependent upon others to initiate the routine, think about what you know about prompt fading. Think about where the child's at in terms of the intensity of the prompt injected into the child's experience by others, and think about how you can systematically over time fade off that prompt and dose that child's responsive behavior with reinforcement along the way so that they are encouraged to become less and less prompt dependent. Very briefly, I'll share with you that there's a device there called the motivator. I've used that before. It looks like a pager. It's hard to tell on that slide, but it's about that big. A little bit like, well, like a pager, smaller than a cell phone. Some of you might not know what a pager is, but we all used to wear them in the 90s. And on a set schedule or on a variable schedule, it will vibrate. And the child can wear that or keep it in their pocket. And when it vibrates, just like a cell phone, it vibrates, the child can be taught to stop and think, do I need to go? Yes, I do. I better get going and get in there. That's great for children with very serious executive functioning concerns or ADHD, who are just so busy in their environment that they don't realize they need to go until it's too late. Either they're not going to make it there in time, or they're certainly not going to make it there in time. They're already wet. And so these are some nice things we can use. By the way, sidebar, motivator, you don't need to buy the device anymore. It's a nice app. I think it's a $3 app you can put on your phone. So that might work for some children as well. Thinking about older children who can have a phone or similar device with them, you can get that motivator app. One of the most common kinds of concerns, though, is, hey, what happens if we're going to toilet train here at EI or at school, but we can't count on the parents to do that? Or the parents say, well, we're willing to do this, but school's already told us they won't get involved. Well, it's best if we can be consistent across settings. I'm stating the obvious here, I understand. But recognize that even if the child can only train in one setting, that's still gold. You can do a lot by training in only one setting, at home or at school exclusively. Often what will happen is the child will develop the skill in one setting, and then they'll teach the partners in the other setting what they're up to, that they're using the toilet now. And so sometimes there's a kind of spontaneous generalization. It's actually not spontaneous, but for today's purpose, we'll think about it as it just generalizes as the child becomes more and more successful. Or once the child's reliably going in one setting, there's some reasonably simple generalization strategies that can be used to increase that skill across settings. So the moral of the story here for current purposes is, if a teaching staff says, hey, we can't count on the parents to toilet train, they've got too busy a life going on at home, and so it's just us. So I say, well, great, our work at school just got more important, not less. Same with home life. If the parents say, well, we can't count on them toilet training at school, so my response is, well, our work at home just got more important, not less. We can still initiate, even though it's not across settings. Okay, we'll generalize later. And there's two ways of generalizing too, colleagues. One generalizes across settings. There's actually multiple types of generalization, but I'm thinking broadly here for a moment. There's generalizing across settings, like home to school or school to home, but there's also generalization across time. So even if they're not going to be able to toilet train in this current classroom, live with the faith, I humbly submit to you, live with the faith that next year there's going to be a teacher that runs with the ball. Or there's going to be a change in the home environment at a later date where they're a little more freed up and they can focus on this now. Or eventually, frankly stated, a child might move to a group home as a young adult where they can really focus on it. So live with this notion that you can generalize across settings and you can generalize across time. They're both critical to the child's progress, to the constituents' progress. Oh, and finally, anxiety. This is why I wanted to take a few extra moments. You don't usually get a question when anxiety is the key. You get a statement. You get something like this. The trainer says, I give up. He wins. He can just wear a diaper. I can't do it anymore. The child is demonstrating anxiety, sometimes so severe that it mimics a panic attack. And under those conditions, here's what I invite. Come together as a team. Have a behavior analyst or a psychologist or somebody who's very knowledgeable about functional assessment sit in on the meeting and ask these questions about what is it about that training experience that's anxiety provoking. It could be a whole bunch of things. I bolded a few things here. Maybe it's the toilet flush. Maybe it's the task is just so difficult, it's overwhelming, like fine motor difficulty. Maybe it's the loss of the diaper that's just been overwhelming for this child who's used a diaper for 11 years. Think about how children with autism, for example, have a propensity for routine and sameness. And then finally, there might be a history of pain there that toilet's associated with. There's all sorts of reasons why somebody might experience anxiety as it relates to sitting on the toilet, and really slow down as a team and hypothesize what that might be, because that's how you're going to address anxiety. Okay? And very often, when the child demonstrates a lot of anxiety related to sitting on the toilet, one has to set as an initial goal that they walk in to the bathroom, sit on the toilet for 2 minutes or 3 minutes, and then remain reasonably calm. That's the goal of training initially. We'll worry about the urine stream or the feces landing in the bowl at a later date. Initially, it's just going to be a matter of getting in the bathroom, sitting, and getting out under control, reasonably calm. That's a very honorable goal. It's a very appropriate goal to maintain during the early stages of training for a child who demonstrates anxiety related to the toilet. Okay? Yeah. Think about that functional assessment. If they're tantruming upon approach of the toilet, there's probably some aversive history there, or they're missing out on something that they really enjoy. And so there's some things there we can do to shape their success, like making those things they enjoy contingent upon practice, making sure that they understand that they're not going to miss out on a favorite part of the school day. And now you're going to see me just wind up for a conclusion. If this were a flight, I'd be inviting you to put the tray tables up at this point. And it's in that sense that I'm just going to put a wrap on this, just by giving you a general notion of how this might roll out in our concluding moments. First thing we do is think about a baseline skills assessment. Make sure the child can sit for 30 or 45 seconds and remain reasonably still. That's what we need. Don't have the child sit on that toilet for too long, or get into a grudge match where you have them stay on the toilet until they go. It's not going to work. It's just going to drive up their displeasure with the toileting routine, their displeasure with you, and make training more difficult. Quick trips, no more than 5 minutes. In fact, in my toilet training research, I have written right in my manuals a 5-minute rule. No more than 5 minutes on the toilet, unless, of course, the child's actively productive. Let them finish out. But just 5 minutes of sitting on the toilet. If they don't sit there for 30 or 45 seconds reasonably calmly, that's where our work begins. There's my 5-minute rule. How important is it that the learner relaxes while on the toilet? How important is it? Critical. It's right up there with having a full bladder and sitting on the toilet as the other key variables in success. The child needs to relax a little bit. In fact, that's become increasingly clear to me across my career. I worked with Richard Fox, who is a great behavior analyst and psychologist, one of the great experts in our field. I had a chance to work with him a while back related to developing toilet training manuals. And that's one of the things he taught me. He said, Dan, one of the things that you haven't focused on enough in your career is how important it is that the child learn to relax when they're sitting on the toilet. So everything we know, occupational therapists included, thinking about your expertise here, everything we know about sitting on the toilet and relaxing, helping the child to do that is critical. Okay? Not forever, for 2 minutes, for 3 minutes, no more than 5 minutes. Briefly, there could be an intensive training schedule. This is great. You can often get a quick acquisition this way, but there's some disadvantages. If you have the child sitting regularly across the day, like a weekend, you can do some intensive training, and you might be able to rough the skill in quickly. But oftentimes parents, teachers, and the child find that intensive schedule very aversive. If that's the case, then this intensive toilet training schedule of multiple hours of training, for example, across the weekend, might not be the best match. In fact, it often is not. There's a data sheet that you can use. That's what it looks like. Yeah. For many of us, it's a gradual approach. And what that gradual approach looks like, I'm coming in for a landing now, in case you wanted 2 points to make it, and then we'll close it out. What the gradual approach looks like is the teaching staff and or the parents pick periods of the day or periods of the family life each week when they can really focus in on training, maybe 3 hours on Saturday and 3 hours on Sunday, or 2 hours after school each night before the child's bath routine, bedtime routine. You see how that might work? Or in the morning when there's a gap between ready for school and the bus. Pick these intervals where you can really conduct the intervention with a great deal of fidelity, and you can really attend to the child and really promote those relaxation skills we were talking about a moment ago, and dose their success wherever they're at in that journey of becoming good users of the toilet. In summary, with regard to this particular portion of the workshop, what I would share with you is the following. I'd much rather see a smaller unit of instruction, like 10 hours per week of instruction with great fidelity, rather than great units of instruction, 25 hours per week of instruction, but it's done with a great deal of duress and disorganization. Smaller with greater fidelity is going to be better, in my opinion, for everyone involved, including the learner. Okay, that was one point. Hey, what separates a good toilet training interventionist from a great one? What separates a good toilet training interventionist from a great one? Here it is. I thought I had it there, but it's just up here. What separates a good interventionist from a great one is the following. When you implement that toilet training procedure, there's going to almost assuredly be a moment in the training when it looks like all is lost. It looks like it's not going to happen. It looks like the child's not interested. It looks like we're wasting our time. It looks like this is going to be aversive for all parties involved. The great toilet training interventionist recognizes this as a part of the journey and does everything that she can in order to facilitate staying the course, pushing through that desert, that period of discomfort, that desert of reinforcement, that dearth of reinforcement for all parties involved until they get to the point where they can say, hey, you're making progress. This is happening. The great interventionist is an optimist. They are a tough-minded optimist. They're thinking to themselves, I know this is hard work, but it is going to happen. And I'm going to be the leader who really supports everyone with active troubleshooting and perseverance. That's the great toilet trainer. That's the characteristics. That's what you hear them verbalize, at least to themselves. Okay? The first couple of days are very important. So stay close to your constituents. If for example, you're helping parents and now they're going to try toilet training at home, touch base with them quickly. If you met with them on Friday, call them on Monday and ask them how it went. Because that's when we know what our course corrections need to be. We can troubleshoot quickly. And also, it's tough. They need some feedback quickly so they know they're on the right track. So that training behavior doesn't fall on extinction. Okay? You know so much more about what a child needs in order to be successful after you run toilet training programs for a day or two. It's just the nature of the business. We always know more after we get started. That's why it's good to touch base quickly. And watch for ruts in training. Sometimes children get really comfortable not using the toilet, even though we're training. Change it up. Find some new reinforcement. Find different visual supports. Change up the schedule. Make sure that they have a need to use the toilet by having them drink a little more water during the day. Whatever you need to do, don't allow them to become comfortable with an alternative to using the toilet during training. Remember, our jobs as therapists and as teachers and as parents is not to make our child's lives too comfortable. It's to challenge them to acquire new skills. Okay? I'm not suggesting make things overly aversive for them, but I bet you can understand the distinction I'm making. If you see a training rut, and the training rut is setting the occasion for the child being comfortable now, urinating on the bus instead of during the school day, we need to make a change. We need to troubleshoot that. Okay, I think I've got more here. I'm sure I do. You can read these vignettes. Oh, good, look at that, we made it. So I'm really pleased with that. Share with you briefly, as was noted at the top of the hour, I'm Dr. Mruzek. You can call me Dr. Dan. Most people do across my career. There's 2 emails for you. One's my university address, and also I'm a clinical director at Proud Moments ABA. And so you can contact me at either site. I'm always glad to hear from you. I hope you found this useful. I appreciate your good work with these wonderful children, and I wish you all the best. So thank you very much and have a good day. Bye now.